All right, let me get where I can share my screen. All right, now let's get started. All right, so today is GI Day 3. So there's a lot of information in Day 3, but I've added some helpful hints and stuff on the PowerPoints. There's smiley faces, stuff like that. So that should be there to help you. And I will send you guys my notes also. This way you have it. All right, so GI Day 3, we're going to start with the hepatic portal system. This is so the liver has 4 lobes that are surrounded by connective tissue that divides into lobules because the liver is divided into different lobes, and it's supported by an intra-abdominal pressure and various attachments called mesenteries. Um, unless the liver is fairly large or it's fatty, you typically won't feel it. If you can feel the edge of somebody's liver, that means they've got something going on. It also has a system of veins that transport blood from the GI tract to the liver. So this is your hepatic portal vein. Um, so the portal vein transports blood from the intestinal tract to the liver and provides about 80% of the liver's blood. Then you have the superior mesenteric vein, the inferior mesenteric vein, and the splenic vein. So the liver gets a lot of rich blood supply. The hepatic artery provides 20% of the body's or the blood supply to the liver and is rich in oxygen. But the portal vein blood is high in oxygen or is low in oxygen, but it's very high in nutrients. So it carries a lot of the nutrients across where it needs to go. So the liver functions, it helps produce bile. Think of your liver as the fish tank, remember? So your liver is kind of your filter, your charcoal filter for your fish tank. And if you eat a lot of fatty food, drink a lot of alcohol, or have anything that affects your filter, what happens is you have that buildup of um, toxins, essentially. The liver also produces certain proteins for blood plasma. It aids in the production of cholesterol and special proteins that help carry fats through the body. So this picture also has some other functions that it does. So around 80% of bilirubin is made from the breakdown of hemoglobin in the senescent red blood cells, and then are prematurely destroyed erythroid cells in the bone marrow. So this chart here shows how bilirubin is metabolized. So you have old dying red blood cells, and then you have the mononuclear phagocytic system. You have the breakdown of red blood cells that makes heme. Then you get biliverdin, bilirubin. Then the bilirubin gets bound to albumin. Then you have the conjugation, and you have conjugated bilirubin. And this is stored in the gallbladder. So I think here later we'll talk about jaundice and how it affects like newborns or people that have liver dysfunctions. So the remainder originates from the turnover of the various heme-containing proteins found in other tissues, primarily from the liver and the muscles. So here's your smiley face. So some of the diagnostic testing that we do for the GI system is a bilirubin test. I highly recommend you know these normal bilirubin levels, specifically the total bilirubin level. Anything greater than 1 is going to be an issue. Your newborns, which we'll get to here in a second, tolerate a little bit higher of a level of bilirubin because their livers are immature and they don't break it down and process it like adults do. A bilirubin test can diagnose liver disease, biliary obstruction, something called erythroblastosis fetalis. This is something you can develop as a newborn, and hemolytic anemia. So for this test, they need to be NPO except for water 4 hours prior to the test. Then you have your liver enzymes. So you have your AST. Normal level is 0 to 35. If it's elevated, you can have an MI, hepatitis, cirrhosis, hepatic necrosis, a hepatic tumor, acute pancreatitis, acute renal failure, and acute hemolytic anemia. And then you have your ALT. Normal levels are between 5 and 35. And they are elevated with hepatitis, cirrhosis, hepatic necrosis, hepatic tumors, and hepatotoxic drugs. Then you have your LDH. Your normal levels are 100 to 190. They're going to be elevated with an MI, pulmonary infarction, hepatic disease, pancreatitis, hemolytic anemia, and skeletal muscle disease. You do need to know these levels. So AST is an enzyme that helps convert globulins, and that's a byproduct of protein, to amino acids. So they take immunoglobulins or globulins and transform them into amino acids. ALTs is an enzyme that helps convert proteins to energy for the liver cells to use. Then you have your alkaline phosphatase. Normal level is 30 to 120. It is also an enzyme that our body uses to help break down proteins. We'll often draw this lab in conjunction with a gamma GT. While the ALP is often used for many processes in our body, it is very important in the role of our liver with bone formation. So if it's elevated, you can have obstructive disorders of the biliary tract, hepatic tumors, cirrhosis, primary metastatic tumors, hyperparathyroidism, a metastatic tumor in the bones, and healing fractures. Your gamma GT is responsible for transferring molecules and plays an important role in assisting the liver with metabolizing drugs and toxins. So if it's elevated, you can have hepatitis, cirrhosis, hepatic tumors, hepatotoxic drugs, MI. This will usually show up 4 to 10 days after an MI, congestive heart failure, and alcohol ingestion. So if you think of the gamma GT helps metabolizing drugs and toxins, if you look at hepatitis and cirrhosis and tumors and drugs, these are all things that are can be due to some type of drug that you're metabolizing or a toxin. Same thing with your ALP. It helps break down protein. So and it also has a major role in bone formation. So if you have metastatic tumor in your bones or healing fractures, you can see that there. The liver also stores a lot of other enzymes that we're not necessarily going to go through. And then any injury or disease that affects the liver will cause a release of these enzymes into the bloodstream. A serum protein, your normal values for your total protein is 6.4 to 8.3. A normal albumin is 3.5 to 5. Globulin is 2 to 4. And albumin globulin, or your AG ratio, is 1 to 2. So globulin is different than hemoglobin levels. So don't get them confused. Globulins play an important role in liver function and blood clotting and fighting the immune system. Albumin helps to transport substances like medications, bilirubin, fatty acids into the bloodstream. So if you have hypoalbuminemia, it's going to lead to toxic levels of medications in the blood and elevated bilirubin levels. So albumin is going to be very important in determining the patient nutrition status because a low albumin level can lead to protein calorie malnutrition. We know protein is essential for wound healing. So if you have a low albumin level, this can lead to an increase in retained fluid due to a decrease in capillary permeability. Then we have our blood ammonia. A normal ammonia level is 10 to 80 micrograms per deciliter. Ammonia is normally converted into urea and then excreted by the kidneys. With liver dysfunction or altered blood flow, the liver causes blood ammonia levels to increase and BUN, or your blood urea nitrogen, to decrease. So you need to notify the lab if your patient is currently taking neomycin because this could cause a decrease in ammonia levels. The thing with ammonia, though, is if you have higher levels of ammonia in the body, that can manifest into encephalopathy. So think about what signs and symptoms you would have with encephalopathy, right? So you're going to have a lot of confusion, a lot of restlessness. So with an elevated ammonia level, you're going to see somebody that is confused. They can be combative. So just remember that. Some of the diagnostic studies is you can do a liver scan. So they give a radioactive material that sends out gamma rays to light up the liver and is visualized in a scanner. The radioactive material is absorbed by the liver and the tissue, and then leftover is absorbed by the spleen and bone marrow. So this test is done to determine how well the liver is working. And any abnormalities like tumors, abscesses, hematomas, a liver enlargement, or cysts will be shown here. If the spleen lights up more than the liver, then the portal hypertension is going to be suspected. So with this test, there's no prior prep that's required, but you do want to make sure if they have an allergy to iodine or contrast dyes, and they will need a pregnancy test. Anytime you give any type of contrast or radioactive particles, then you want to make sure that they're not pregnant. With the liver biopsy, they take this is to help confirm diagnoses of liver disorders. So they'll take a needle and insert it through the abdominal wall and into the liver to remove a piece of that liver tissue. They usually go between the 6th and 7th or the 8th and 9th intercostal space. They'll need to be supine with the right arm raised over their head. The patient has to stay calm and hold their breath, usually for about 10 seconds while the needle's inserted, and then the client is able to resume breathing once the needle is removed. So they have to kind of hold their breath while the needle is in or being inserted, while they're gathering the stuff, and then once it's removed, they can breathe out. They do need to have an informed consent. They need to be NPO 48 hours prior. And you want to assess lab results for normal platelet count and prothrombin time. So if these are abnormal, this is going to put them at a greater risk for bleeding. The liver is very vascular, as we talked about a minute ago. So anything you do to it, you want to make sure that you're not gonna cause more harm. These to do a liver biopsy, this is just going to help diagnose cirrhosis, if they have hepatitis, if they have drug-related reactions, granulomas, tumors, etc. This is kind of the definitive diagnosis way. After the biopsy, you want to make sure this is very important, so you'll need to remember this. Afterwards, you need to position the client on the right side for at least 2 hours following the biopsy. So the reason for this is the liver capsule or that connective tissue layer covering the layers is compressed against the chest wall, allowing for a splinting sensation to that area. So that you can help, it acts like compression to help avoid bleeding or any leakage of bile. After a liver biopsy, they're going to be monitored in post-op for at least 4 hours. And then after about 48 hours, any dressings to the biopsy site can be removed. They should rest and avoid lifting anything over 10 pounds for at least 4 days post-op. So when you get them back to the floor, you need to assess for bleeding. Make sure that they're on the right side with the bed flat, because if they're on their right side and their head's up a little bit, that's going to run the risk of having them bleed there. They'll have vital signs every 15 minutes, then every 30 minutes, and then every 4 hours. Several of those are going to be while they're in PACU. You also want to monitor for pneumothorax. Anytime you take a needle or anything going through to there, you want to make sure to not puncture the lung. So they don't need to do any swimming or bathing for 7 to 10 days. So they don't need to submerge themselves in a tub specifically. But you can shower 24 hours after the procedure. No driving for 8 hours post-op. Going to monitor the patient for abdominal pain. So why do you think we would want to monitor for abdominal pain? So specifically for bleeding or hemorrhage. So if they start bleeding into their abdomen, that's what we want to monitor for. And then if we suspect a pneumothorax, they're going to have shortness of breath, cyanosis, and restlessness. So remember that. So question, after a liver biopsy, the nurse should place the client in which of the following positions? The answer is B. Right side lying position with the bed flat. All right, now we're going to talk about disorders of the liver. Jaundice is also called icterus. It's not really a disease process, but it's a sign of a different disease. So they'll have kind of this greenish, yellow, orange color discoloration of their skin and tissues. And this can accompany disease processes that affect the liver. So their bilirubin, their total bilirubin will be elevated. So any concentrations above 2.5 become visible on the skin, the oral mucous membranes, and the sclera. So if they are at 2, we may not see the effects, but we know that it's climbing. So for a newborn like this, their liver is immature. They can't break down all those excess red blood cells from the mother. So that while it's trying to break down, it results in jaundice. So there are three forms of jaundice. You have hemolytic jaundice, and this is caused by an excess and destruction of red blood cells. There's hepatocellular jaundice that's caused by liver disease, damage to the liver cells that can't clear a normal amount of bilirubin from the blood. Then you can have obstructive jaundice. This is caused by a block in the passage of bile between the liver and the intestinal tract. So it's very important to know the difference in these. So hemolytic is going to be caused by the destruction of red blood cells. So if you think hemolysis, you're destroying red blood cells. The hepatocellular is because it's due to some type of liver disease. Then obstructive is because there's something blocking bile. So causes of excess destruction of red blood cells can include multiple blood transfusions or from a hemolytic reaction due to mismatched blood. That's why we check our armbands and do all those checks that we do for blood. If they have pernicious anemia, sickle cell anemia, um, and then the main disorder, or one of the big ones, is cirrhosis. So cirrhosis is a chronic condition. So once you start to develop cirrhosis, you don't really ever get rid of it. You can treat it and keep it in control, but there's not really a cure for it. So with cirrhosis, liver cells become damaged from alcohol, medications, chemicals, chronic ingestion of acetaminophen, hepatitis, or the blockage of the bile ducts. Main causes, though, of cirrhosis include viral infections like hepatitis B and C, chronic alcoholism, increased fat collections, so like if you're obese, an increase in cholesterol if you have diabetes, bile duct blockages, and autoimmune disorders. So the liver will develop scar tissue, and that holds no function for the liver and can cause blockage of blood flow. So with the stages of liver damage, you have that healthy liver, and then you start to get deposits of fat that cause the liver to become enlarged, and then you start to develop scar tissue. So you have liver fibrosis. And then once you have growth of connective tissue, that destroys the liver cells, and that's when you get develop cirrhosis. So with uh, cirrhosis patho, liver cells become irreversibly damaged. They get replaced by non-functional fibrous connective scar tissues. They have a partial or complete occlusion of the blood channels in the liver. It becomes increasingly unable to carry out its function. So the filter becomes clogged, essentially. Then you have a disturbance in digestion, metabolism, coagulation, fluid electrolyte imbalances. You have the inability to metabolize hormones and detoxify chemicals. And you also have the malabsorption of fat-soluble vitamins. So let's see if I can move the screen down here. So you can see on this picture, you have that healthy liver, and then you have a liver that's been cirrhosed. There are different types of cirrhosis. So there is Lennox cirrhosis, and this is pretty much alcoholic cirrhosis. This is going to be your most common type, and it's characterized by necrotic liver cells. So because it occurs over a period of time, it is characterized by a hobnail appearance of islands of normal tissue that regenerate tissue and scar tissue. So you can see how it kind of looks like it's got these little island places on it where it's got different knobs, and then you've got or these little bumps that kind of come up from it. These are your hobnails. Um, so the changes of developing alcoholic cirrhosis increases in women who consume 2 to 3 alcoholic beverages per day, and men who drink 3 to 4 alcoholic drinks per day. And this form usually develops over a period of 30 years. Now, if you drink heavier, then this can happen sooner. So if you're somebody like my dad who drank a 30 pack of beer every day of his life, as far as I knew, his liver was not great. You can have chronic poisoning with certain chemicals. So you can have carbon tetrachloride, which is a cleaning agent, or the overingestion of hepatotoxic drugs like acetaminophen. So those people who try to overdose on acetaminophen end up only damaging their liver, not really having any other side effects of it. Then you have post-necrotic cirrhosis. This results from the destruction of liver cells secondary to an infection, especially Hep C, but can also include Hep B and D. This is a metabolic liver disease. And this is from, so it's characterized by necrotic areas of liver cells, regeneration of tissue, which forms large bands of scar tissue. So with these, you can see these bandings in the different areas of scar tissue. This can be due to exposure to hepatotoxins or industrial chemicals. You will need to know the difference in the different types of cirrhosis. So then you have biliary cirrhosis. So when you have chronic inflammation, this causes destruction to small intrahepatic biliary ducts, preventing the flow of bile into the small intestine. So eventually you'll get cirrhosis and liver failure. So because it's biliary, you can think of the biliary duct. Scarring occurs around the ducts in the liver. Primary biliary cirrhosis refers to a progressive autoimmune disease of the liver. So you have the bile ducts. This is what a normal bile duct in the liver looks like. Can't really find a good place for my face. And then if you have inflammation, it kind of narrows. So you can see the big difference in those two. Then there is NASH. This type is not related to fat buildup from alcoholism, but more specifically from like diabetes, metabolic syndrome, anything that causes increased fat production in the liver. So this is technically considered non-alcoholic fatty liver disease. That's what NASH stands for. So not all people have fatty liver will go on to develop cirrhosis, but some with fatty liver will develop inflammation and fibrosis of tissue and eventually develops cirrhosis. So this is typically caused by, like I said, diabetes or elevated cholesterol and coronary artery disease. So you have a normal liver, then you have lipogenesis, then you develop the inflammation, and then you develop the fibrosis. That's the difference in these. So here's a chart. Still cannot find a good place. Oh, thanks, you. So there are 2 categories of cirrhosis. You have compensated and decompensated. So with compensated cirrhosis, the symptoms are less severe. So the patient's going to have more flu-like symptoms, loss of appetite, nausea and vomiting, general weakness and fatigue. They can have indigestion, abnormal bowel function, flatulence, abdominal discomfort, but most of the pain is located in the epigastric region as well as that right upper quadrant. Objective data obtained in the compensated cirrhosis is a low hemoglobin, fever, and weight loss. With decompensated cirrhosis, this is a late stage. Symptoms can include several of the compensated, but they're going to be more severe. They're also going to have jaundice, shortness of breath, itching, severe fatigue that affect their daily lives. Itching is another symptom from the accumulation of bile salts under the skin caused by jaundice. Objective data for decompensated includes epistaxis, which is just a nosebleed, purpura, which is those purple splotches on your skin, hematuria, spider angiomas, bleeding gums, things like ascites, spleen enlargement, hemorrhage from esophageal varices or other distended GI veins. They'll have mental disorientation and abnormal speech are seen in late stages and are caused by increased ammonia levels. So remember we talked about that earlier. So this chart, so you have compensated, so you have stage 1 and stage 2. So in stage 1, you have no varices, no ascites. Stage 2, you have esophageal varices, but no ascites. With decompensated, you have ascites, or you'll either have ascites or varices or both. In stage 4, you're going to have bleeding and or ascites. So you're going to have lots more complications from that. So with disorders of the liver, there's lots of signs and symptoms, as you can see here. The main ones I want you to focus on are clay-colored whitish stools, and that's what this picture is up here. They're going to have dark tea-colored urine, pruritus. So this is the itching caused by the accumulation of bile salts. So if someone that has liver disease or cirrhosis and they are itching, that's all because of they have bile salts that are accumulated into the skin. See, they can also have develop ascites, like I said, and there'll be jaundice, and this is because they have bilirubin spilling out into the blood. So some other disorders are edema in their legs and feet, something called caput medusae, so they'll have veins in their abdomen that are dilated. This is one picture. I do have another picture from day 2 that it may be more distended, but this is kind of what it is. So Medusae is like Medusa, the from Greek mythology. So this is supposed to look like thin snakes, etc. You can develop gynecomastia. This is where you have enlarged breast tissue. And this is because the liver cannot completely metabolize estrogen. So men develop gynecomastia, testicular atrophy, palmar or erythema. So they'll have really bright pink palms and cutaneous spider angiomas. And this is due to an increase in estrogen. So there are other signs and symptoms. So you have the palmar erythema, like I just talked about. This is where they'll have very bright pink palms. Spider angiomas, which is what this picture is here. Other symptoms will include cognitive changes, altered sleep and wake patterns, something called asterisk, and this is a liver flapping tremor. So they'll have a tremor where their hands kind of tap up and down. So that is a coarse tremor characterized by rapid, non-rhythmic extension of the extension and flexion of the wrist and fingers. So it's a lot of just tapping. We're also going to have something called fetor hepaticus, and this is a fruity or musty odor to their breath. So with these patients, you're going to see a prolonged PT, an increase in their INR. And this is because they have the inability to store vitamin K, which is essential in clotting. So this is going to increase your PT, your INR time, and low platelet count will be affected that way. You can have a decreased cholesterol, abnormal electrolyte levels. You're definitely going to have an elevated bilirubin, AST, ALT, LDH, and GTT. You're going to have a decrease in total protein and albumin. You will have increased ammonia levels, low blood glucose. On CT and MRI, you're going to see an enlarged liver. You'll see the nodule configuration and distorted blood flow. They're going to diagnose, they'll do a liver biopsy, like we talked about, to diagnose if there's fibrosis of the tissue. And this is going to be the most conclusive diagnostic procedure. They may do ultrasound scanning to just distinguish the density of scar tissue and other types of cells. But we're mainly looking to see like what the tissues look like, and is the liver enlarged? Is there other things that are causing problems? All right, then there are nursing interventions. So treatment is to first and foremost eliminate causes. So you want to decrease the buildup of fluids in the body and prevent further damage to the liver. So they need to eliminate alcohol, any type of hepatotoxins, and environmental exposures. So we want to monitor their vital signs. We also want to do daily weights because they will have edema. Monitor strict I&O, their abdominal circumference, and their mental status. The prognosis and treatment is going to depend on the severity of the bilirubin albumin level, as well as the severity of the fluid retention from the ascites and the edema. So initially, we want to put them on bed rest and closely monitor their eyes and nose. They're typically going to be restricted on their fluid intake to 500 to 1,000 mils a day, with a sodium restriction of 1,000 to 2,000 milligrams per day. So we want to educate them on diet, on their diet, vitamin and nutritional supplements, a sodium and fluid restriction, like I talked about. They need to have small, frequent meals, abstain from alcohol. And for skincare, they need non-drying agents, so nothing with alcohol in it. Pat dry and apply lotion. We also need to administer vitamin K. We're going to give a vitamin B complex, vitamin C, iron. We're going to give IV albumin, which is going to help restore plasma volume and improve edema. We're also going to give lactulose. Lactulose is going to be administered for elevated ammonia levels, and it works by drawing water into the bowel, causing diarrhea. And so stool is going to be where the majority of your bilirubin is excreted. Then you have cholestyramine. This is binds to bile acids in the GI tract, making it insoluble. So this can cause nausea, constipation, and discomfort. But these are sticking together. It helps relieve itching. That's the big thing there. And then Actigal, or your Sodiol, helps dissolve gallstones that are not able to be removed by surgery. So if you have obstructive cirrhosis, this can be an option. So for these patients, they need a protein-rich diet, and high in calories. And if they have malnutrition, we can treat that with enteral or parenteral feedings, but absolutely no alcohol. And we talked, I think, day one about how to measure abdominal girth. This is never going to go away. So this is just the diagram of how to do that. Okay, now we're going to talk about complications of cirrhosis. Hmm. So one of the complications of cirrhosis is portal hypertension. So the portal system consists of gastric veins from the stomach, the mesenteric veins from the intestines, the splenic vein from the spleen and pancreas, and the portal vein. All drain into and through the liver and out of the hepatic veins and into the inferior vena cava. Cirrhotic liver causes compression of the intrahepatic veins, so they're not able to move blood as as well. So blood starts to back up into the portal system, causing an increase in fluid pressure and congestion in the portal system. And this is just a diagram of the hepatic portal circulation. So you see there's a lot of blood flow involved. Some complications from portal hypertension, or so portal hypertension, as normal pathways become obstructed, collateral veins become distended and engorged. So you'll develop esophageal varices, which is what this is. So these are those distended veins in the esophagus. Can cause hemorrhoids because we're increasing the pressure. And then this is another picture of that caput medusae. See how it's almost like ribbon or snake-like? This is if you have, so portal hypertension can cause buildup and backflow into the veins. We're having that bad weather today, and I'm getting messages and everything. All right, a complication of cirrhosis with portal hypertension. So you guys are going to restrict sodium because the whole goal is to reduce the amount of fluid that's accumulating. So you're gonna, so with the sodium restriction, that's going to help decrease the amount of water being pulled. You're going to administer spironolactone. This helps reduce fluid by blocking aldosterone. But you want to monitor potassium because this is a potassium sparing. You want to watch for hyperkalemia. So with this one, you're going to monitor their levels at day 3, week 1, and then monthly times 3, and then yearly after taking this medication. But this one, you also want to monitor for gynecomastia. We're also going to give furosemide to promote urinary excretion. So you can be on both spironolactone and Lasix or furosemide. Then you're gonna get we'll give propranolol, that's a beta blocker to help reduce blood pressure and the pressure in that portal system. So we want to decrease that pressure uh, to help get rid of some of the side effects. Um, and then they may do a surgical shunt. It's not used frequently because it is a higher risk for shunt failure. But if they have to have it placed, they'll do there are non-surgical shunt placements. So there's a TIPS procedure. So this is a transjugular intrahepatic portosystemic shunt. This is typically going to be the preferred method. It involves a cannula with an expandable stent that's inserted into the portal venous system through the jugular vein. And the stent shunts blood from the portal vein to the hepatic vein, bypassing the liver. So another complication of portal hypertension is going to be esophageal varices. We talked about that, I think, on day 1. We know that's from an increase in pressure. Um, so esophageal varices are those superficial veins in the esophagus that are prone to bleeding. It can bleed a very small amount. It can bleed a ton, but it also can be life-threatening and will require immediate intervention. Once bleeding begins, clotting disorders occur, and that's common with liver damage. So with this, you can do a barium swallow or some type of scope to confirm the diagnosis. You can also see it on CT or MRI. So this is just the patho from when the portal hypertension starts to have resistant portal flow and increased venous inflow. Then your pressure gradient increases in the portal vein and the vena cava. And then you can have venous collateral circulation develops from high portal system to systemic veins forming esophageal, gastric, and humeral varices. And then the varices can rupture, causing life-threatening hemorrhages. So with esophageal varices, they need to be on a soft diet, abstain from alcohol, no aspirin-containing products. So that's anything with aspirin or aspirin itself. So if you think about other things that might contain aspirin, things like I think some Excedrins do, Pepto-Bismol, things like that. No irritating substances. We also want to give antitussives and stool softeners if they have a lot of coughing or straining, because coughing and straining increases the vascular pressure. So if they have an active bleed, we can do a balloon tamponade. So this is a balloon that's fed up through the nose, down through down the esophagus. And this uses a Singstack and Blakemore tube in emergency situations. It has four separate openings. Two are used to inflate the two balloons, and two are used for aspiration of esophageal and gastric secretions. So once you blow up the balloon, you can draw out all that excess blood that's settling in the esophagus and in the stomach. Blood does not belong in the stomach. Another complication is ascites. This is a collection of fluid in the peritoneal cavity. It increased pressure forces serum proteins into the peritoneal cavity. Protein draws out plasma from the blood by osmosis. The kidneys decrease blood volume and the renal blood pressure by initiating RAS. Remember that. And then sodium is conserved and increased fluid retention. You'll have low blood volume, and that can suppress the antidiuretic hormone by causing water to be reabsorbed. So to resolve ascites, they do an abdominal paracentesis to remove fluid. So they can remove anywhere from 6 to 8 liters in 60 to 90 minutes. And they can remove 15 liters over a longer period of time. You're going to give IV albumin to help pull back fluid into the vascular space. And then we're going to monitor blood pressure and urine output to evaluate the effectiveness. So if we have low urine output, then we know that we've got to do something. So this is somebody that has ascites. So you can see how their belly is, or their abdomen is very rounded. If you did your percussion on it, you would almost hear like a tympanic drum. So with these patients, you want to do a sodium restricted diet. We're going to give them spironolactone. We're going to monitor abdominal distension. So what do you think is a way that we can do that? We're going to measure abdominal girth. And these patients are going to need high calorie, high carbohydrate diets. And then these are the different types of shunts. So this is the one that goes through the jugular, down through here. So this is the shunt. And then this is the paracentesis. It goes through the wall and helps to drain all the excess fluid from within the abdomen. So for the paracentesis, to position them, you have to set them upright on the edge of the bed or in a high Fowler position. And then you should empty their bladder prior to the procedure to avoid puncturing the bladder. You want to obtain baseline vital signs and a baseline abdominal girth and weight and baseline labs. A complication of a paracentesis, though, will include hypovolemia because we're moving an exorbitant amount of fluid from the body, so that can cause a fluid shift. And then we want to monitor for a bladder perforation. So if they have hematuria or low or no urine output, they'll have suprapubic pain, distension, and fever. They can even develop peritonitis, which is a sharp, constant abdominal pain. They'll have fever, nausea, vomiting, and diminished or absent bowel sounds. So another complication would be hepatic encephalopathy. This is when you have central nervous system manifestation of liver failure. It can lead to coma and death. So what happens is ammonia forms in the intestines by bacterial action on ingested proteins. The liver converts to urea, which is excreted by the kidneys. The failing liver can't break down the ammonia, so ammonia accumulates in the blood. Ammonia crosses the blood-brain barrier and enters the brain cells. It interferes with brain metabolism, cell membrane pump, and neurotransmission. So if you have somebody that has hepatic encephalopathy, just the encephalopathy alone, if you think back to neuro, what signs and symptoms you would see with a patient like that. So if you know that you have a patient that has cirrhosis and they are having confusion, they're restless, or any other symptom that may accompany encephalopathy, you know that that's something you need to monitor for. Very important. And then so with the hepatic encephalopathy, they'll become very disoriented, confused. They may even have personality changes. I've seen sweet little ladies become hellish grandmas. I've seen all kinds of stuff. They may have memory loss or asterix. This is that flapping tremor. And so they'll have just that continuous flapping. They'll have a positive Babinski reflex. So when you stroke their foot, it causes the great toe to extend and the other toes fan out. So a negative Babinski, they're going to go up and around and their toes should curl. But if it's positive, their big toe and everything will kind of fan backwards. That's not a normal thing. We don't want that. They're also going to have that Photora hepaticus. That's that sulfurous breath odor. They could be very lethargic and go even into a coma. And then these symptoms will worsen after eating a high protein meal or if they have an active GI bleed. So nursing interventions, we're going to limit dietary protein and low sodium diet. We want to give laxatives and enemas to help deplete intestinal microorganisms. Ammonia is formed by intestinal bacteria along with digested proteins. Depletion of the intestinal microorganisms can lead to a decrease in ammonia levels. We'll give antibiotics to help destroy any intestinal microorganisms responsible for the ammonia production. Typically, we're going to do neomycin or kanamycin are going to be preferred because they are poorly absorbed in the GI tract. So they're not going to affect anything in the GI tract. So they're not going to be absorbed. We're going to give lactulose. This comes in a very thick liquid. If they're taking it for liver disease, they're typically going to take it 3 to 4 times a day. It can be mixed with a half a glass of water, milk, or fruit juice to help improve the taste. It's very thick and very, very sharp tasting. Um, it does cause frequent bowel movements and can cause gas and nausea. If the diarrhea, gas, or nausea continues the patient should be instructed to notify the provider. They should maintain around 3 to 4 stools per day, but if they're having lots of stools, you need to have them monitor for dehydration and continue to monitor albumin levels or the ammonia levels to determine if it's being effective. We're going to give levodopa that works by restoring normal neurotransmission into the brain. We're going to give IV fluids to replace electrolytes and TPN to replace any vitamins and minerals. The prognosis for anybody with hepatic encephalopathy is very poor. They're often going to require a liver transplant. These patients will have an activity intolerance. So you want to assess their ability to perform their general ADLs. Can they get up out of bed? Can they wash their hands? Can they brush their teeth? They need frequent rest periods because they're going to tire very quickly. So they need to conserve their energy. They need a high protein, high calorie, unless it's contraindicated. They need to set short-term goals. So a goal like getting out of bed and walking to the bathroom without being short of breath. So short-term goals that they can meet fairly easily. They need to have smaller, more frequent meals, and they will need a dietitian consult. If they have nausea and vomiting any nausea and vomiting, you can give them antiemetics prior to meals. And you can involve family and dietitians in meal planning and preparation. So that's specifically just so they can eat the foods that they enjoy, while still ensuring that they have the nutritional requirements within those dietary restrictions. But it's still very important for patients to feel like they have options and a say in what they eat, as long as they're eating, things within their diet that they need to. So to assess these patients, we want to assess their respiratory patterns. If they are short of breath, the natural thing to do is raise their head of the bed, and then we can give them supplemental oxygen as needed. We're going to measure their abdominal girth daily. Because their abdominal girth may be enlarged, that can push pressure up on their lungs, so that can cause an ineffective breathing pattern. So something that is super easy for you guys to do is if they're having difficulty breathing, they're short of breath, raise their head of bed. Super easy, right? And then you want to monitor their edema location and to what degree do they have edema. Monitor their albumin levels, infusion rates, turn every 2 hours while in bed so they don't accumulate excess fluid or they develop edema. You're going to monitor for bruising, nosebleeds, petechiae, and bleeding from the gums. Okay, so from here, we're going to move on to hepatitis. So with hepatitis, If you have exposure to toxic chemicals, drugs, alcoholism, or infectious microorganisms, these cause inflammation to the liver shortly after exposure. The most common cause of hepatitis is through viral infections. Other causes include autoimmune hepatitis, toxic hepatitis, whether through chloroform, phosphorus, or carbon tetrachloride. These all cause liver necrosis, and the prognosis is poor with this type without liver transplant. You can have drug-induced hepatitis, because drug reactions can be harmful to the liver. These are things like anesthetic drugs, antidepressants, anticonvulsants, and high doses of corticosteroids. Should also know that any more than 3,000 milligrams of acetaminophen in a day can damage the liver. It's found in a lot of cold and cough medicines, and you should educate your patients on monitoring for the intake of acetaminophen during periods of illness. Hepatitis can be acute or chronic. It can be caused by a secondary infection with another virus. A viral hepatitis is the most common, and the incubation period and modes of transmission are different depending on the different types of hepatitis, which we'll talk about shortly. So this chart, I cannot stress enough, is going to be very important to know because you're going to need the modes of transmission for each one for your test. So you have Hep A, and it's oral route from feces and saliva from an infected person, comes from food, water, and equipment contaminated with HAV. And then here's your signs and symptoms and the outcome. You have your Hep B, which is infected blood or plasma, needles, syringes, surgical dental equipment that are contaminated. Hep C is from infected blood or blood products or sexual contact. And you'll have signs and symptoms that are similar to HBV, although it's less severe and without jaundice. You have your Hep D, that's the same as HBV. It can't be affected alone. It occurs as a dual infection with HBV. So if you have HBV, you can develop a hepatitis D. Hep E is a fecal oral route, very low risk of person-to-person contact, and it's found more often in countries that have poor water sanitation and poor water quality. And then you have Hep G, that's infected blood or blood products. So Hep A is fecal oral route. Hep B and C are going to be blood or sexual contact. But this is also associated with liver cancer. Hep D can't occur alone. It has to occur with Hep B. So those are the big ones. So be sure and you review this chart, make flashcards, make sure you know the type, cause, how it's transmitted, and what signs and symptoms you're going to see. Very important. Signs and symptoms of hepatitis in general. All forms have the same phases. They have an incubation phase where the virus replicates within the liver. In the incubation phase, you're asymptomatic. Late in the phase, the virus will be found in the blood, bile, and stool, and then you're considered infectious. So once you're positive for it, that's your late incubation phase. Then you have the pre-icteric or prodromal phase, where you have symptoms of nausea and vomiting, anorexia, fever, malaise, arthralgia, headache, right upper quadrant discomfort, enlarged spleen, liver and lymph nodes, weight loss, rash, and urticaria. Then you have the icteric phase, where you have jaundice, itching, clay-colored or light stools, dark urine, fatigue, and anorexia, radical quadrant discomfort. And then the pre-icteric phase can still continue on even through the icteric phase. Post-icteric phase, you're going to have liver enlargement, malaise, fatigue, your LFTs start to return to normal. If you have chronic hepatitis, you can have a prolonged PT or PTT. You can have a low blood glucose or a low serum albumin. So these patients, so to diagnose these, you're going to do a serologic analysis to determine viral antibodies, and you can do RNA testing to identify the virus, but that can usually take a week for the results. You're also going to look at your white blood cells. So these patients need to be on bed rest, have small balanced diet with several feedings. So they need several small balanced meals throughout the day. You're going to give IV fluids as ordered. You're going to give vitamins as needed, antiemetics. In chronic cases of B, C, and D, you're going to give recombinant interferon alpha 2B or intron A with Ribitol. The intron A is used to force the virus into remission along with a type of synthetic antiviral. It's used to treat respiratory syncytial virus or RSV. It increases the response to treatment and helping keep the client virus free for more than 6 months. If they don't respond to treatment, your next option is going to be liver transplant. They can do immunosuppression. And then there's a preventive measure for hepatitis transmission. I think that's the page that I showed you. So hepatitis isn't just a huge chapter, but you need to know the differences and how to treat it, right? Now we're going to do disorders of the gallbladder and pancreas. So disorders of the gallbladder and pancreas. The first one we're going to talk about is cholelithiasis and cholecystitis. So cholelithiasis are stones that form in the gallbladder. And gallstones are going to be the most common abnormality of the biliary system. And then stones in the bile duct are referred to as cholecystolithiasis. So these are your gallstones that can cause inflammation, and then if it becomes obstructed, they kind of stop here. The cause is unknown, but it could be due to bile stasis, dietary factors, and infection. You can have tumors and destruction from scarring. Kicking in the bile duct can lead to cholecystitis. Cholecystitis is an inflammation or infection of the gallbladder. It can be acute or chronic. These almost always coexist with each other, and they're fairly common in middle-aged women with multiple pregnancies, diabetes, or obesity with frequent weight changes. So risk factors, if you're female after age 60, we're seeing it now earlier. Ethnic background, typically Caucasian and Mexican Americans are going to be more prone to them. If you are overweight or obese, that's going to be your strongest risk factor. And then if you have diabetes. We're seeing it in younger people now because we have higher diets that are higher in fat. If you have high cholesterol, you have an impaired ability to metabolize fat. If you have Crohn's disease, low calorie, liquid protein diets, cystic fibrosis, lots of things can cause, are going to be more common in those groups. So symptoms tend to develop when one or more gallstones partially or totally impair the passage of bile. So you'll have belching, nausea, right upper quadrant discomfort, and pain or cramps after high-fat meals. So what happens when you have gallstones? If you have high-fat meals, you have something called cholecystokinin. This is a hormone that's secreted by the small intestine, and it stimulates the gallbladder to send bile for digestion. The gallbladder then responds by contracting forcefully, and then without proper treatment, the gallbladder can become necrotic, rupture, and lead to peritonitis. If you have acute cholecystitis, you're going to have more severe symptoms like fever, vomiting, abdominal tenderness over the liver, severe right upper quadrant pain, also called biliary colic. It can range to the back. The pain can radiate from the back to the shoulders. Some patients may also experience increased heart rate and respiratory rate, as well as diaphoresis, which can imitate signs and symptoms of a heart attack. The gallbladder can even swell and be palpable. You can develop jaundice. Your urine can appear dark brown, and your stools can be light colored. So another way to test is to do Blumberg sign, and that looks for rebound tenderness. But this is only to be done by an advanced practice nurse or a physician. You can have a positive Murphy sign, and that's when you have pain with deep inspiration, when you palpate up underneath the rib cage. So when pressure is applied directly to the ribs, the pain is noted on palpation. One of the diagnostic studies is a gallbladder radionuclide scan, or a HIDA scan. This is where they do an injection of technetium-99. So they'll give that and they'll do a scan to visualize the gallbladder and the biliary tract. This test is used if an ultrasound is inconclusive. So they'll inject that technetium-99 into the vein. It'll bind to the bile-producing cells, and the scan can track the flow of bile from the liver to the small intestine. And images are obtained with the use of X-rays. The exposure to radioactivity is very minimal. So here's your gallbladder, here's your common bile duct, and here's your intrahepatic biliary ducts. So if you see any abnormalities there, this will be determined if you can't see it on ultrasound. These patients do have to be NPO after midnight for this test. And then, if you guys remember, day one, we talked about ERCPs, or endoscopic retrograde cholangiopancreatographies. This is that scope that's inserted down through the esophagus and into the common bile duct via the duodenum. It can identify the presence of stones, tumors, or narrowing in the biliary and pancreatic ducts. Then we have a magnetic resonance cholangiopancreatography, or an MRCP. This is very non-invasive. This is just an MRI with oral and IV contrast. So when it's lit up, you can see the liver, the gallbladder, the stomach, the common bile duct, the pancreatic duct, and the duodenum. It's just another way to look at it. So they can do MRCP for other concerns, but this is just one of the ones that you can look at it. For nursing interventions, if they are acutely ill, you want to make them NPO immediately. Sometimes they'll insert an NG tube. You're going to give IV fluids, and if it needs to be removed, then they'll get prophylactic antibiotics in case, because you don't want any bile leakage or anything, or it to rupture before surgery. You can give antispasmodics to decrease pain. Most commonly for the gallbladder, we're going to give meperidine, which is also Demerol, and ketorolac. We'll give antispasmodics like dicyclomine, and this decreases the occurrence of spasms in the sphincter of Oddi. The sphincter of Oddi is responsible for controlling the flow of pancreatic juices and the bile into the duodenum. Morphine, though, is contraindicated because it causes an increase in tone and spasm in that sphincter. And then, like I said, antibiotics are going to be given prophylactically to treat infection, treat an existing infection, and if perforation occurs. And we're also going to give them some fat-soluble vitamins. For mild or chronic cholecystitis, because you can have chronic cholecystitis that doesn't need, where you don't need to have the gallbladder removed, you have to remain on a low-fat diet. Medications are going to give analgesics and anticholinergics. You're going to give a bile-binding resin, cholestyramine or Questran. This is going to be given to relieve itching. If the patient is not a candidate for surgery, they're going to get Actigal or Ursodiol. This can take anywhere from 6 to 12 months to be effective, but has a moderate success rate with a high reoccurrence within 5 years. And then there is Chenix or Chenodiol, and this can take up to 2 years to be effective. These help promote bile and bilirubin secretion and blocks bacterial growth. It can cause uterine contraction and should not be used in women who are pregnant or lactating. If they need surgical intervention, they may have a lithotripsy. So there are 2 types. There's extracorporeal shockwave lithotripsy and extracorporeal lithotripsy. With the extracorporeal shockwave therapy, they have shockwaves that are directed at the gallbladder while the patient lays on a fluid-filled pad. Shockwaves help break up the gallstones where they can be removed through an endoscopic procedure or through direct contact dissolution. So they use a small needle with a catheter that's inserted into the gallbladder, and they'll use fluid to help break up the stones or remove them. The extracorporeal lithotripsy uses laser pulses to create a mechanical shock wave to help break up some types of gallstones. And they use an electrohydraulic probe with 2 electrodes to deliver electronic sparks and rapid pulses to break up the stones. They can use direct visualization with an endoscope, or they can do a percutaneous balloon or basket system. They can do a laparoscopic cholecystectomy, and this is typically your treatment of choice for 80% of clients. It does require general anesthesia and is performed endoscopically by making 3 to 4 small puncture sites in the abdomen. The abdomen is then inflated with carbon dioxide to allow better visualization. And then the surgeon drains the gallbladder, dissects the vessels and the ducts, and then grasps and removes the gallbladder. The recovery time is better, and most patients can be discharged that evening or in the morning following the procedure. They may insert an NG tube during the surgery, but then it's removed before the patient wakes up. They're going to give mild analgesics for pain and discomfort, and then once they anesthetic subsides, they can resume eating. And typically after a week, they can resume normal activity. You do want to educate them that they can have cramping or cramping in their shoulder, and that's due to gas that's been inserted into the abdomen. So these pictures here are like what your scopes would be. So you have your belly inflated with the gases, and these are the little probes that they use to go in. So the physician can see what he's doing using these little handles. And then around 2 months, this is what your scar looks like. And then this is the gallbladder and some gallstones. If they need to do an open cholecystectomy, they'll do that if it's extremely distended and fragile. Um, they'll make an abdominal incision. They'll use a Penrose drain or a vacuum drain. And that's just to help drain any serosanguinous fluid. It is an invasive procedure, so it requires a hospital stay of 1 to 2 days. With an opening approach, they may place a JP drain in the bed of the gallbladder or a T-tube in the common bile duct. So if they have an open, they need to avoid heavy lifting for 4 to 6 weeks, clear liquids directly after anesthesias or the anesthetics wear off, and advance to solid foods when the return of peristalsis. So once they start having gas or have a bowel movement, they can start to have normal foods again. They need to report a sudden change in drainage, foul odor, pain, fever, or jaundice. That could indicate infection or a retained gallstone causing blockage. They need to shower instead of taking a bath while the drainage tube is in place. Stool should return to normal color within a week, and then diarrhea is pretty common directly after. And then the natural orifice transluminal endoscopic surgery, or the NOTES surgery, avoids visible incision and reduces complications. And this procedure, an endoscope is inserted through the mouth, vagina, or rectum. And then they'll go through and remove what they need to. They can also do a T-tube cholangiography. So they'll take a T-tube shaped tube that's connected to a sterile closed drainage system. So the end of the tube exit out of the abdominal wall so dye can be injected, and then X-ray films are taken. And this is, they can look to see if any stones are retained following surgery. Once the T-tube is removed, the site's then just covered with a sterile dressing. Post-op chole, they need to diagnosis of it'll help diagnose any retained ductal stones afterwards. And they can look at the flow through the bile duct. So you always want to make sure and check an allergy to iodine. They need to be NPO after midnight and until the test is complete. And then they'll need a cleansing enema the morning of the test. So they'll do this after the removal of the gallbladder to make sure they have good flow of contrast in the duodenum. So the T-tube will be connected to a closed drainage system, covered with a sterile dressing. If it's removed, assess for allergies to iodine, NP after midnight. With the drainage bag, go to measure bile drainage and document. If they have more than 500 mils within 24 hours, or if it's significantly reduced, you need to notify the provider. After 24 hours, the drainage should decrease, but you don't want any more than 500 mils. So if you have a T-tube, you want to educate them to immediately report any increased pain or decrease in drainage, as this can indicate an obstruction in the tube. You want to assess for infection at the insertion site, and then the physician may prescribe elevation of the tube above the abdomen to prevent total bile loss. You may have to clamp the tube an hour before and after meals to provide the bile needed for digestion. And this also helps determine how well the bile duct is working and if the T-tube can be removed. If they start to have distress, you're going to unclamp it immediately. Over time, the T-tube can be clamped, should be increased until it can be eventually be removed. You want to monitor the stool for color for loss of bile. So it'll go from that brown color to very pale color. Monitor for signs and symptoms of peritonitis. Monitor response to food. The tube may more likely stay in place for about 1 to 3 weeks. And you can expect a brown-green drainage from the tube. It can even be a little yellow in color, but those are all normal. All right, now we're going to talk about disorders of the pancreas. So here's a picture of the pancreas. The pancreas consists of a head, body, and tail. And then you have the pancreatic ducts. One of the disorders of the pancreas is pancreatitis, and this is an inflammation of the pancreas. It's most commonly caused by damage to the biliary tract. Men often develop it due to alcohol consumptions. So acute ranges from mild to severe and can be fatal. Patients are very ill, but pancreatic function usually returns to normal within 6 months. Chronic is classified as a calcifying pancreas, chronic obstructive pancreatitis, autoimmune pancreatitis, and idiopathic hereditary pancreatitis. So risk factors, if you have biliary tract disease or blockage, any alcohol use, complications after an ERCP, if you've had a GI surgery, any metabolic disturbances like hyperlipidemia, hyperparathyroidism, or hypercalcemia, any trauma to the abdomen, peptic ulcers, any medicine toxicity, viral infections like Coxsackie virus, B and HIV, smoking, and genetics. These patients are going to have severe mid-epigastric pain that radiates to the back. It can be in the upper abdominal pain that radiates to both sides and straight to the back. You'll have nausea and vomiting, flatulence, stools may be frothy and foul smelling. They can have steatorrhea, or they'll have an increase in fat in the stool from poor fat digestion. So steatorrhea will look almost like you'll have oil rings in the stool. Their symptoms will worsen with the consumption of fatty foods or alcohol. The pain is relieved when the client sits up and leans forward or curls into a fetal position. They may be jaundiced. So one way to diagnose this is a CT scan or an ultrasound of the pancreas. In an acute attack, you can have severe constant knife-like pain. That will be worse when they lay down. A serum amylase and lipase will reveal elevated levels. The levels can be up to 3 times the normal range. This is going to be a definitive diagnosis for pancreatitis. So in pancreatitis, the ACEs are high. So ACE as in high carbs. So your amylase and lipase. Elevated amylase levels in themselves are not specific to pancreatitis because they can be elevated with perforated peptic ulcers, perforated bowel, or diabetic ketoacidosis. A pancreatic amylase is more specific to pancreatitis. In chronic pancreatitis, serum lipase often remains elevated and serum amylase is normal. They can have diminished bowel sounds, a distended abdomen, tenderness to palpation. They could be hypertensive, so they can have hypovolemia or shock. They can have fever, tachycardia, shallow respirations. In severe pancreatitis, that can result in bruising around the umbilicus or flank. So that is Cullen's, called Cullen's sign, and this is due to a decrease in the amount of platelets. They can also have elevated serum and urine amylase, lipase, and liver enzymes, or their bilirubin might also be elevated. So you want to monitor electrolytes, and the CT may show pancreatic edema and necrosis. So one of the ways to diagnose, they can have a serum amylase. Normal range is 30 to 200 units per liter. So any damage that occurs to the pancreas cells or obstruction to the pancreatic ductal flow cause an outpouring of this enzyme and absorption into the bloodstream. Levels will rise within 24 hours of onset of pancreatic disease. It's rapidly cleared by the kidneys, so the levels may return to normal within 48 to 72 hours. But if they've had any IV dextrose, this can cause a false negative. A urine amylase normal range is 3 to 48. Any disorder that affects the pancreas can cause elevated amylase levels in the urine because the kidneys rapidly clear it. Levels remain elevated in the urine for up to a week. And it can be used to diagnose pancreatitis in patients who have had symptoms for 3 days or longer. So they can do a urine collection, maybe 2-hour spot urine, 6-hour, 12-hour, or 24-hour collection. With those, you always want to record the time, like the exact time the collection began. Always discard the first specimen. Collect all subsequent urine, including the last voided urine, exactly 2, 6, 20, 12, or 24 hours after the collection began. And then the urine should be collected kept on ice or in a specific lab refrigerator during collection period. For labs, we're going to monitor white blood cells. This can be due to inflammation and infection. Platelets are going to be decreased. Your calcium and mag are going to be decreased due to fat necrosis. Your liver enzymes and bilirubin are going to be increased due to biliary dysfunction. Your blood glucose levels will be increased due to decreased insulin from the pancreas. Remember, insulin is secreted from the pancreas, and you can have your ESR or erythrocyte sedimentation rate will be elevated. So you want to keep them in PO until they are pain-free. You can do an NG tube to allow gastric decompression. This is if they've had severe vomiting or if they've had a paralytic ileus. We're going to give IV albumin. TPN, for severe pancreatitis, and then atropine, uh, anticholinergics, and pancreolipase. When we do start their diet back, it needs to be bland, high protein, low fat, and no stimulants, so no caffeine. And they need to have small, frequent meals. The pancreolipase aids in digestion of fats and proteins, so it needs to be taken with meals and snacks. It can be sprinkled on top of non-protein foods. You want to drink it with at least 8 ounces of water following, and then wipe the lips and rinse the mouth after taking to prevent skin breakdown or irritation. And then you want to monitor for life-threatening alcohol withdrawal. So can you think of symptoms that might look like alcohol withdrawal? They're going to start having confusion. They're going to have tremors. They're going to become tachycardic. So the things you want to watch out for, you want to look at their blood sugar levels, keep up with their INO. You need to monitor for any cardiac dysrhythmias, their electrolyte levels, or any bleeding. So you want to educate them to have a food high in protein and low in fat, small, frequent meals, abstinence from alcohol, caffeine, and any black pepper digestive stimulants. So you can do black pepper, like aromatherapy, anything that can be digestible, you want to make sure and avoid. With chronic pancreatitis, you have prolonged and progressive inflammation of the pancreas. Typically, alcohol is going to be the cause. It can lead to edema of the duodenum and decrease the tone of the sphincter of Oddi. So with that, duodenal contents could move into the pancreatic duct. Other causes include hereditary hyperparathyroidism, hypertriglyceridemia, autoimmune pancreatitis, trauma, and anatomic abnormalities. Over time, though, you're going to have fibrotic scarring from the recurring inflammation, and will cause hardening, and endocrine and exocrine functions are partly or completely lost. You remember the pancreas is both an endocrine and an exocrine gland, so it serves multiple functions. Signs and symptoms will have severe to persistent pain, lots of weight loss. They may have flatulence, vomiting, and diarrhea. They can have pseudocysts in their pancreas. And these are just cysts that are a buildup of that junk in the pancreas. You can develop a secondary diabetes, so you'll have an increased appetite, thirst, and urination. You can feel a firm mass in the upper left quadrant. You'll have dark urine. Stools may be light in color and foul smelling and have fatty streaks in the stool. So that's what this is. This is like the steatorrhea. See how it's got like an oil ring around it? It's got little streaks of stuff. They may also have peripheral edema and ascites. With these patients, you want to educate them on a fat-free diet and abstinence from alcohol. Their treatment is also going to depend on the cause. Medications, we're going to give pain medication. Demerol is discouraged due to risk for seizures, especially in older adults. Most of the time, whenever I had patients with pancreatitis, they were getting morphine or Dilaudid. Usually, I think it was Dilaudid. For mild pain, you can give acetaminophen or ibuprofen. You can do an opioid analgesics like codeine or tramadol. Sorry, morphine causes spasms of the sphincter of Otis. That's what we're not going to give morphine. We may need to give insulin, pancreatic enzymes like creon and panzyme. And then complications can be fatal. You can develop hyperglycemia, necrosis, and hemorrhage. So you see this picture here, how you've got fatty necrosis and these little hemorrhages throughout. You can develop peritonitis, severe fluid and electrolyte imbalance, shock, pleural effusion, acute respiratory distress syndrome, coagulation problems. Elevated calcium levels can result in tetany and convulsions, and you can have these pancreatic cysts and abscesses. All right. Any questions while you're reviewing this? If you have any questions while I'm at the conference, I will have my phone on me, so I will check emails here and there. So if you have any questions, you want follow up on something, please let me know. There is a heads up for this section, and I do highly recommend looking at the topics on Moodle under the GI help. There are pictures, they help talk about ways to remember. So I'd highly recommend reading any of those articles, anything that might be useful for this exam. If you guys don't have any questions, I'm going to stop the video and good luck.